Sam?
دكتور محمد.
Okay. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. It's a great pleasure for me to announce the continuation of our BANHA orthopedic review course. As many of our attendees and our colleagues are overseas, so we will try to speak in English as much as possible. As you know, all the BANHA orthopedic review course comprises two main sections. The first part is the orthopedic, and the second part is the trauma part. The orthopedic, we started with the knee section, first knee arthroplasty, then we will go to arthroscopy, then we will go to the hip section, then to the foot and ankle, and go from foot and ankle to the shoulder, and from the shoulder to the elbow, hand, and finally the spine course. And after the spine, we will continue with pediatric, deformity planning, oncology, and finally metabolic and neuromuscular disorders. After we finish orthopedic course, we will go to the trauma course, comprising all the trauma of all the regions in orthopedics. This course is sponsored by the Egyptian Orthopedic Association, and it is certified by BANHA University to be legalized to have the CME certificate of this course. You have to make a registration on the Microsoft form, as we mentioned in the site. After you make the registration, you have to attend at least 70% of the course. We have two sessions before, and now the third session of the course is with our dear brother, Professor Dr. Wael Nassar, Professor of Orthopedic Surgery at Shams University. He will speak to us today about a very interesting topic in total knee arthroplasty, which is total knee arthroplasty, which patient and which prosthesis. It's a very demanding talk. For myself, Professor Muhammad Al-Ashhab, Head of Orthopedic Surgery, and all the organizing committee, I would like to thank, many thanks, Professor Dr. Wael Nassar for his precious time that he will spend with us this night. Thank you, sir. The moderator of this session today is Professor Dr. Hussam Al-Bigawi, Professor of Orthopedic Surgery, BANHA University, and Head of the Knee Arthroplasty and Arthroscopy Unit in BANHA University. Go on, Dr. Hussam B. Thank you so much. Dr. Hussam Al-Bigawi.
Dear orthopedic surgeons all over the world, I'd like to introduce Dr. Wael Nassar, Professor of Orthopedic Surgery at Shams University.
May you please raise the voice, Dr. Hussam? May you please raise the voice?
I'd like to introduce Dr. Wael Nassar, Professor of Orthopedic Surgery at Shams University. The lecture title is Total Knee Arthroplasty, which proceeds for which patient. Dr. Wael, تفضل.
Thank you, Dr. Al-Ashhab. Thank you, Dr. Hussam, for this kind invitation. First, all thanks to Allah for His kindness, support during these hard days that we are all going through because of the pandemic and the quarantine. Second, I'd like to thank Professor Dr. Muhammad Al-Ashhab and his team in BANHA University for inviting me to this wonderful and respectable course. Last but not least, I would like to thank Professor Dr. Soufiane, our colleague from Tunisia, because his last presentation made my mission easier for continuing from the point that he stopped with. I'd like to start my presentation with this sentence, which I like very much. Fortune and luck loves prepared minds. Going back to our presentation, by prepared minds we mean you have to see your patient carefully, examine your patient carefully, spend enough time with preoperative planning. If you did these points, your mind will be prepared and the fortune and luck comes to you and your patient, inshallah. Intended learning objectives of my presentation is talking about constraints. What do we mean by constraints? Different types of total knee prosthesis, how we choose the suitable prosthesis for my patients, and how to be flexible in shifting from one decision to another decision inside the operation. Knee replacement surgery is a solution to knee pain in over 500,000 patients each year in the United States. About 200 total knee prostheses being operated every year in my university, in Shams University, average 5 per week, of which is 30 to 40 revision cases. Aseptic loosening of total knee prosthesis is the most common cause of failure in both the unconstrained and the semi-constrained type of prosthesis. 70 to 80% of cases had the diagnosis of osteoarthritis, 10 to 15 are rheumatoid. Other indications are much less common and includes tumors, AVN of one or more femoral condyles, and other much more rare causes. If we are going to our Egyptian patients, which have certain unique features sharing with most Middle Eastern patients, patients usually seek medical advice in the advanced stage of the disease, where more conservative techniques in arthroplasty is needed. Varus deformity is much more common than valgus deformity. Flexion is more than recurvatum. Most cases have severe varus with severe internal tibial torsion, and we will see during this presentation what this dictates in our surgical technique and implant choice. Many Egyptian primary total knees is comparable to difficult revisions in Western countries. Augments, blocks, and extension stems should be available on shelf to avoid unhappy ends for you and your patients. This is one type of a primary knee osteoarthritis that we see in our clinics in Egypt and in other Middle East countries. The patient usually is reluctant to seek surgical treatment during early phases, and he is postponing the surgery, taking more medications, more analgesics, till he comes with such a picture, which is much more comparable to difficult revision cases in many Western and US countries. Prosthetic options, if we are talking briefly, elderly or low demand, middle-aged, uncomplicated patients, we usually put cemented, cruciate substituting, stemless, fixed bearing, total condylar designs, and then we think if we will resurface the patella or not, the concept of selective resurfacing that my colleague, Dr. Sufyan, has talked about in his last presentation. Younger, more active patients, we can go for a cementless total knee, which is uncommon practice in Egypt so far. Ceramic on ceramic total knee, which is yet not available in my country. Mobile bearing total knee with many designs available in the market and in Egypt. Single radius total knee introduced by Scorpion company, which is called Scorpion 2. Medially biased kinematic knee, or the concept of medial pivot knee that Dr. Sufyan illustrated enough in his biomechanical presentation about the kinematics and biomechanics in the last presentation. Although it's most recent, but is not yet widely introduced in Egypt. Hyperflex designs available, but more expensive, and you have to talk with your patient about his expectations. Hyperflexed designs is considered and designed to allow hyperflexion of the knee in exceptional situations, and not like many doctors and many companies that propagate for their prosthesis as it is the prosthesis of sitting squatting or sitting cross-legged or sitting in the prayer position. Although the design allows this degree of flexion and range of motion, if the patient is doing this on a daily basis, there will be accelerated wear and he will be faced with an early revision, maybe in the 6 or 7 years post-operative. What are our goals in doing total knee arthroplasty? We are aiming at pain relief, improving the function of the patient, attaining acceptable stability, putting a durable implant, and if possible, correction of the deformity as much as we can. Our targets, we have to put the component in good position, we have to respect the limb alignment, we have to get balanced collaterals, and we have to ensure equal gaps. Finally, the suitable implant design. The first 4 points are covered in the surgical technique, which is beyond the spectrum of this presentation. And this presentation is only for number 5, suitable implant design. What are my variables in choosing which implant for which patient? The age of the patient, meaning by the age is the physiological age and the functional demands, not the chronological age. Level of activity, I have seen a few of my patients, 75 and 78 years, playing tennis and playing playing golf. And I have seen females at 58 or 59 years hardly wants to go to bathroom and go back to bed. So you have to talk with the patient and to ask the family about the baseline activity. The extent of the pathology, the deformity, bone deficiencies, which I talked about in our primary knees comparable to the severe deficiencies present in difficult revision in other countries, and the instability issue. Which is more important, surgical technique or choice of the implant? If you are asking me, surgical technique is the key for success. Choice of the implant is the good tool which could be used by a good surgeon to achieve good results. There are some principles to guide the design of prosthesis which replace the diseased or worn articular surfaces while retaining the ligaments and muscles. The components should be shaped to allow distraction, sliding and rolling movements between the bones according to the 3-axis policy that Dr. Sufyan talked about. Components should apply only compressive stresses to the juxta-articular bone. All surviving soft tissues should be kept and restored to their natural tension, and the areas of contact between the prosthetic surface should be large enough to maintain the pressure under load at a level which the prosthetic material can withstand. With the new replacements and the new concept of one-day procedure, one-day hospital, swift total knee, the patient should be able to go walking just 2 hours after the end of the surgery. I like this sentence very much, which is present in every book talking about total knee arthroplasty. The success of a knee arthroplasty is influenced by the complex interaction between the implant design geometry, which is our target today, and the surrounding soft tissue structure, which serves to determine the range of motion, interface force, and stability of articulation, which is the art of arthroplasty related to surgical technique and experience of the surgeon. If we are talking about soft tissue restraints controlling knee replacement, we have the collaterals in one hand, the medial collateral and the lateral stabilizers. Talking here about the lateral collateral and the posterolateral corner. On the other hand, the cruciates, the ACL and the BCL. The implant design, we are talking about the constraint, which is the built-in stability of the implant design, load sharing capacity of the implant, interface forces affecting the bearing and reflected on the wear, tibiofemoral conformity, contact stresses, and kinematics, which are covered in the last presentation. The constraint options is the amount of inherent built-in stability that the implant provides. The least constraints is the unicompartmental, that's to say you have to have good collaterals, good cruciates, good soft tissue coverage, so that you need minimal inherent stability in the implant and maximal stability of the soft tissues. Going a step further, the mobile bearing designs, the gender-specific designs, cruciate retaining, cruciate sacrificing, then the posterior stabilized, constrained condylar, or in other words, the super stabilized designs, rotating hinge, and finally the fixed hinge. This is the step ladder, continuation, and progress of the constraint. Conformity reflected to contact stress. The more conformity you have, the less the contact stress per unit area, as shown in the right slide, or right part of the slide. The less conformity you have, the more stress per unit area and consequently, the more wear you have. This picture reflects what I'm talking about. If you have this military shoes, it has wide base, strong, distributing the wear on a large surface area, so that allows the soldier or the worker to accept and to do high load activities. While the very nice shoes, feminine shoes in the left picture, although it gives minimal impression that's hardly noticed, but this impression is profound. And if this works on ceramic or on soft tissues, the stress per unit area leaves disastrous and long-standing effects. So the wider the conformity, the less the stress, and the longer the survival. Starting with the least constraint, as I said, the unicompartmental knee. What are the indications? The age of the patient is usually above 60 with low activity, which is changing nowadays. Articular destruction is limited to one compartment, reaching to bone, and the concept of anteromedial arthritis is now well pronounced. Stable knee, coronal and sagittal, intact anterior cruciate and medial collateral with minimal or no dissection and release on the medial side. If we are talking about the medial unicompartmental, varus deformity should be less than 15. Flexion deformity should be less than 15. No inflammatory arthritis, that's to say it's not for rheumatoid or systemic lupus patients. Good range of motion, no or mild patellofemoral arthrosis, and normal BMI. The unicompartmental arthroplasty needs unicompartmental disease. The age range is a matter of debate, but nowadays it's more and more decreasing, and the limit is acceptable to start to give the patient the offer of a unicompartmental knee is going down as we have long-term results and better long-term results that satisfies us that this prosthesis can stand the test of time. The deformity should be minimal, and it is unicompartmental knee concept is not aimed at correcting deformity. Of course, it's not for rheumatoid patients. Why? Because in unicompartmental arthroplasty, you are depending on the integrity of the cruciates and collaterals. Rheumatoid disease, on the other hand, is a progressive disease that endangers the integrity of collaterals and cruciates. So you cannot depend on what you cannot justify and cannot trust. You need a functional anterior cruciate ligament. This is the baseline and the ideal patient. Although some patients is talking about if your patient had a deficient ACL, you can do an ACL reconstruction beside your replacement, but this is not the standard. The patellofemoral tracking should be good or accepted, and the patient should have good preoperative range of motions. Osteonecrosis is a debatable issue. Some surgeons say it's a good indication. Others say that the soft bone underlying your prosthesis makes your possibilities of success is limited. Indication of limited knee replacement, let's say unicompartmental. Unicompartmental disease with minimal or no affection of the other compartments. It could be medial, it could be lateral. Some surgeons now considering bicompartmental uni, that's to say medial uni with lateral uni, provided that the collaterals are okay. Grade 1 or grade 2 patellofemoral cartilage degeneration are not contraindications of medial or lateral uni. Limited patellofemoral replacement, that's to say the patellofemoral arthroplasty is not widely used, and worldwide less than 10% of all arthroplasty. The mobile bearing designs. It needs a young active patient. It accepts higher BMI. It needs a stable knee because it depends on the integrity of the collaterals. And it needs to reach at end of your surgery a balanced collaterals and balanced gap. It needs a better preoperative kinematics. It's a load-sharing prosthesis, provides better conformity, less contact pressure, but the issue of backside wear is still there. By mobile bearing designs, we mean that the polyethylene can move in 15 degrees rotation for each side, internal and external rotation on the tibial base plate. And in some designs, it can move anteroposteriorly with translation between 10 and 15 millimeters. reducing the wear provided by this type of prosthesis is a matter of debate, but what is not a matter of debate, what will come in the few next slides. The tibial rotation forgiveness. Many patients, especially in the Middle East and in Egypt, when you adjust the rotational design and the rotational position of the tibial implant, you are going in a dilemma, whether to adjust with the tibial tuberosity, or to adjust with the anterior chin of the tibia, or to adjust with the center of the ankle. And you will spend 10 or 15 minutes in some cases trying to solve this problem. If you are using a mobile bearing design, which allows already 15 degrees rotation each side, you have to worry less about this problem because it's forgiving for 10 or 15 degrees of this rotation. But patellofemoral tracking forgiveness, again, it's related to the previous point. If you have TT, TG distance is abnormal, and you have some confusion to adjust the rotation, this rotation of the polyethylene on the tibial base plates is forgiving in the patellofemoral tracking for you in the operation and for the proprioception of the patient post-operatively. What's not forgiving is the gaps. You have to adjust the flexion extension gaps. You have to adjust the medial and lateral gaps, because if it's not adjusted, your component of polyethylene may be dislocated. Types of mobile bearing designs available is the meniscal bearing, rotating platform, medial pivot kinematic knee, high flexion mobile knee, and dual tracking knee, which failed to stand the test of time. If we are talking about the patellar replacement concept, in the current concept joint replacement meeting during the last December in 2019 in Orlando, USA, the consensus reached these conclusions. 50% of them replaces the patella and 50% are not replacing. Advocates of patellar resurfacing claims that the risk of reoperation in patients with non-resurfaced patella is 10 times more in the first 2 years because of the anterior knee pain. Opponents clarify that this is not a proof that the reoperation is due to patellofemoral problem, but may be due to problems other than that, mainly the rotation and the correction of the synovitis. Both groups do peripatellar cauterization in the absence of evidence base for this, and I think this is a common practice for most knee surgeons in Egypt. Use the smallest, thinnest possible components to replace the patella. Remaining thickness should not be less than 14 or 15 millimeters. 14 millimeters in females, 16 millimeters in males. So that most of the surgeons now are going for the concept of selectively replacing the patella depending on the patient and the degree of erosion and arthritis in the patellofemoral component. Cruciate retaining designs. If you are planning to retain the posterior cruciate, you have to think about many points. First, the preoperative range of motion, so that PCL retention is not the implant of choice if the patient has a significant limitation of the preoperative range. Femoral rollback and should be calculated accurately to avoid increasing the stresses in the posterior part of the polyethylene. Proprioception, near normal gait preoperative, stability preoperative, ligament control of horizontal forces, prosthetic cement bone interface wear, but for which patient we offer this design and this choice. We have to think that the posterior cutout for PCL is relatively less conforming, and if you could not balance the tension in the PCL, it's better to shift to the PCL substituting designs. And as I said before, because most of our patients come at a late stage with severe flexion deformity, severe varus deformity, deficient range of motion, maintaining a good tension after recession or releasing the PCL is a matter of great debate. That's why most of our practice in the Middle East area and in Egypt is going towards the PCL substituting designs. What about high flexion knee? When I went in my fellowship in Germany, I asked them, was 2008, I asked them about high flexion knee. And they said, oh, Dubai's knee. You mean the total knee that's propagated in Dubai? They are criticizing the high campaign made beyond this design, providing it as a solution for each patient wants to sit on the ground, to pray every day on the ground, because they said it's not designed for that. It is designed simply to improve the range, to give the patient a choice to make use of his flexion, not to make this 5 times per day, every day, so that whatever polyethylene you put there, it will be worn out and you have an early revision. There's some modifications in the femoral component that allows this degree of flexion. The posterior condyles is more spherical. The anterior flange is more away from the anterior surface of the femur. And there is also the changes in polyethylene. What are the uses and reflections of these changes in designs? We have to go to the concept of jump distance. Because the patient will do such a degree of flexion, which is 130 or 140 degrees, you have to have your jump distance lower down. You have to have your jump distance larger than usual, and the contact is lower than normal, so we will not have dislocation of the knee with such high degree of range of motion. Also, there should be modifications in the polyethylene and tibia. This part here is showing the changes between the ordinary polyethylene and the polyethylene of the high flexion design. Again, this is the slide talking about the difference in jump distance and point of contact in high degrees of flexion. This is one of my patients, 6 months post-operative and 2 years post-operative. You have the range. As long as the patient has a pre-operative good range, you can reach this range. But you have to warn your patient, this is not for everyday use. This is not for use 5 times a day. This is to be used when needed, when you need this degree of flexion, as going in and out of the car, as going up from a low chair, and such circumstances. Posterior stabilized designs. This is one of the designs, the bisurface knee prosthesis, introduced during the early 2001 and 2002. It has a unique ball and socket joint articulation, mid-posterior portion of the femoral and tibial component. It's a posterior stabilized. It treats that the knee joint as 3 joints: tibiofemoral medial joint, tibiofemoral lateral joint, and patellofemoral joint. This is from the biomechanical point of view. The problem is that on the practical basis, this design failed to show acceptable, good change in the patient satisfaction and proprioceptive rehabilitation for the patient after surgery. That's why it's not widely distributed. Cruciate substituting, it is our workhorse. This is the design that we are doing every day. It allows correction of the severe deformity, whether fixed varus or valgus or flexion. It's simpler technique, allows more conformity, increased mobility. It is indicated in different posterior cruciate balancing and avoid seesaw effect seen in the posterior cruciate retaining designs. There are 2 types of substituting the PCL mechanism, whether the cam and post theory or the increased dishing theory. This is the PCL substituting designs with cam and post mechanism, whereas this is the post introduced in the cam of the femoral component. And as I said before, if this post is longer, you have the high flexion knee designs. But I would like to emphasize again and again and again, that's the most important point and indicator for post-operative range of motion is the pre-operative range of motion of the patient. How to substitute the PCL function? We have the cam and post, we have the increased dishing, and finally we have the hinge. The super stabilized designs, we have a wider polyethylene post, a larger cam, and a more fit here so that minimal degrees of instability in the collaterals. And if your patient has a lateral thrust, these designs can compensate for this. What is the evidence so far? There is no clear evidence for possible superiority of the cruciate retaining or cruciate substituting designs if proper patient selection is respected. Medial pivot designs, although promising, but still needs to stand the test of time. Going for the modularity and the modular constraints, you have to have all these in every knee arthroplasty operation. That's why, or that's because many of our primaries are comparable to the difficult revision. Also, you may have sudden مفاجآت يعني sudden surprises inside the operation as stress fractures, unnoticed preoperative deficiency, fractures of one of the condyles, so that you have to have all these in every primary case you have. This is the shape of the distal and posterior femoral augment, although it's mainly used in revision cases, but you have to have it in each primary case you have, especially difficult cases with high, severe degrees of flexion deformity, of varus deformity, or of valgus deformity. This is the shape of the tibial augments and tibial half blocks or wedges. And this is the stem extensions of the tibia and the femur. Talking about the stem, we are using more and more stems nowadays, especially in the tibial side. Why is that? Tibial stems in the primary knee is indicated, in my opinion, for rheumatoid patients with poor bone stock, osteoporotic patients other than rheumatoids, stress fracture in the tibia, whether evidenced before the operation or introduced and diagnosed intraoperative. If you have tibial tubercle osteotomy, if you have a previous high tibial osteotomy with the screw holes that makes the part of the bone below the tibial base plate is weak, so you have to bypass these weak points of the screws by the stem, and of course in revision cases. Now we have the cones versus the sleeves that you can use in primary and in revision cases. Of course, in primary cases, we are talking here about the very difficult flexion and varus deformities that you need to compensate for the deficiencies in absence of allografts in my country. The complex primary knees like this knee needs to be prepared with many options in the operation, retaining the final decision after doing the balancing of the gaps with the flexion extension gaps or mediolateral gaps. In older times, we have more difficult for reconstruction using K-wires and screws, putting bone grafts to correct for the deficiencies. But of course, nowadays we have the sleeves and the cones that makes life much easier. This is one case which have a medial defect that's compensated by this half block here shown and long stem to bypass the weak part here of the bone. Grossly unstable knees like this needs super stabilized or hinged designs. When to use the fully constrained implants? Constraint should only be used in revision or in difficult primary cases after the principles of extension, flexion gaps, and medial and lateral collateral ligaments are well balanced and performed. As little constraint as possible should be used. If stability cannot be obtained, only then progressive level of constraint should be tested and used in construct. Going back to the concept, first surgery, then implant design and constraint. Fully constrained implants, the tibial and femoral components are linked to each other in a hinge, whether a rotating hinge or a fixed hinge. Advantage stable implants does not require much bony and ligamentous support. Tumor revision case prosthesis can be used in revision cases. Disadvantage, supraphysiological forces produced causes implant and bone wear, especially in the bone cement and cement bone, in the implant cement and cement bone interface. The hinges could be a fixed hinge or a rotating hinge. This is what we mean by the fixed hinge. Although it's much more stable, of course, but on the other hand, it puts much stresses on the end of the stem bone interface in the femur and the tibia. It is mainly for grossly unstable knee and for some cases of tumors limited to the articular surface. Here, as we see, the hinge is fixed, allowing flexion extension only, no rotation at all is allowed. For the patient proprioception, patient will be much less satisfied than the patients with rotating hinge. But on the other hand, if we are talking about stability issue, this is much more stable than the rotating hinge. This is the rotating hinge, allows some degree of internal and external rotation, and allows, of course, flexion and extension. The rotating hinge, you should consider the jumping distance that increases with inlay thickness. There is modular hinge mechanism. There is 6 anatomical femoral sizes. There is 360 degrees femoral offset. You have bone preservation of the femoral and tibial designs in the new designs of the rotating hinge compared to the old designs. There are 6 anatomical tibial sizes, 360 tibial offset option in the stem, standard stem and offset stem, cemented or cementless stem extension. This is example of rotating hinge in grossly unstable knee after consuming whatever you need time to get balanced gaps. Tumor prosthesis is the final end when you have no other choice. This is completely constrained, but on the other hand, the soft tissues are declined altogether. More stability is obtained, but much more stresses on the implant bone interface is introduced. That's why it's mainly for very low demand patients and tumor patients. Even with the rotating hinge, you can have this dislocation if you couldn't balance your gaps. So I put this slide at near the end of my presentation to say that whatever the constraint of your design, it's not an alternative for good surgical technique. In conclusion, success of total knee arthroplasty is partially dependent on targeting the right implant design from a wide spectrum of knee prostheses, ranging from unconstrained unicompartmental to fully constrained implants, towards the right patient in order to achieve the goals of stability, durability, and total knee replacement. Soft tissue restraints, collaterals in one hand, cruciates on the other hand. You have to have good soft tissue sleeve and balanced collaterals. The expectations, you have your own expectations, you have the patient expectations, you have to tell your patient what's allowed for everyday activity, what's allowed exceptionally, and what's the dangerous activities like contact sports, jumping sports, running, or jogging. Hot topics of today for knee arthroplasty in designs: cemented versus cementless, ceramic total knee arthroplasty, patella to resurface or not, all polytibial components coming back again, أنا صوتي مسموع؟
ايوه يا فندم تمام.
مسموع دكتور وائل، مسموع يا فندم.
تمام. All polytibial components coming back again in low demand patients. 1 millimeter increments of polyethylene. يعني the polyethylene inserts now allowed is not like the old one, 9, then 11, then 13, then 15. It's going 1 millimeter. Patient-specific instrumentation, computer navigated total knee, kinematic versus mechanically aligned knees, tourniquet use versus carbojet use, stemmed primary knees more and more nowadays, DARE, which is the abbreviation given by the English people for debridement and implant retention for septic and prosthetic joint infection, SWIFT or fast track total knee arthroplasty. All these are hot topics. Each one of them we can talk in a special and different presentation. Take hospital, because all of us are locked home now. We are not home, so take hospital message instead of take home message. In primary knee arthroplasty, there is no one size fits all. Although design selection is very important, but proper patient selection and the meticulous surgical technique remains the key factor for success. Good preoperative planning saves the time, stress, and the cost for the patient and the surgeon. This is the picture with Dr. Al-Ashhab. Last time we went abroad together in Germany. I hope these days come again. And finally, thank you and stay safe.
Thank you, Dr. Wael Nassar, for his valuable presentation. And if there are questions, we can ask.
Well, may I ask you a question, please?
Sure, sir.
I said to Professor Sofiane that the high flexion knee design, we get a larger and bigger range of motion, but I think this is irrespective of the durability of the implant. Of course, the wear rate will be much higher than the ordinary designs. You agree with me, sir?
Of course. As I said in this presentation, when I went to Germany, they are talking about high flexion knee as Dubai's knee, the commercially available knee. Because in many countries in Middle East, many surgeons provide this for the patient, that this is the solution for the problem of praying in sitting position. This is not designed for that issue. The high flexion knee is designed to allow the patient, which already have good preoperative range, to achieve this range post-operatively in exceptional situations. Not to be done 5 times every day, 5 times per day, every day. Of course, this is allowed by the design, but you will end in a catastrophic early failure. You have a revision after 6 years, 7 years, 8 years, and this is not the issue for the design. So the first determinant of the range is the preoperative range. This design is good as long as you and your patient are understanding what is designed for.
Yeah. May I ask another question, sir?
Of course, of course.
The second question for you, sir, you know, of course, sir, the big debate between the high tibial osteotomy and unicompartmental knee in medial compartmental osteoarthritis. What do you think about it, sir?
I think they are designed for different categories of patients.
Yeah.
If your patient is a young age group, highly demanding, like working in construction, working a driver, something like this, you need something to withstand such degree of stresses. And I think this operation is the high tibial osteotomy. On the other hand, if the patient is office worker, middle-aged, especially female or housewife, and needs to go back to her ordinary life in a faster time, with accelerated or shortened rehabilitation, this is the type of patient you can offer for a unicompartmental knee. So this is, I think it's not different of a decision, it's different in patient selection.
Yes, sir. If I make, sir, if I admit unicompartmental knee, does it make total knee replacement more difficult if I need it?
No, at all. But on the other hand, you have a lower threshold to change to total knee arthroplasty than the ordinary patient. That's to say, when you do a unicompartmental knee for a patient and then he comes after 4 or 5 years and complain of knee pain, you directly go for a knee arthroplasty. But if your patient is a genuine knee with no unicompartmental, you expect and expend much more time in conservative treatment, physiotherapy, local injection, and pain control modalities before you can think to shift to a total knee. So doing a unicompartmental knee makes decision for an arthroplasty in general easier and earlier for the patient.
Thank you, sir.
Dr. Wael Bey, I have 2 questions. One from Dr. Osama Abdul Rashid. What about the weight of the patient? Is it direct to us or not? And the other question about the obese patient. What about the total knee for obese patients and market obesity?
Okay. In obese patients, there is 2 considerations. First consideration is the surgical technique consideration and soft tissue. You have to modify your approach to modify your handling of soft tissue according to this. because they have more and more difficulties and complications. As regard the design, for patients, you have to select the more stable and the higher constrained implants, and don't bet on the integrity of soft tissues. That's to say, if you are between you go substitute. If you are between the ordinary substituting or the super stabilized, you go for a super stabilized. You shift a step further because the patient's weight puts much more emphasis on the left. This is in one hand. In the other hand, there is more space for a mobile frame designs if you can achieve balanced collaterals in such patients, because the wear is distributed in two surfaces, the femoral tibial contact and the tibio-tibial contact surface. Also, there is more room for using stems in the primary surgery for such patients.
Second question, Dr. Hussam.
There are two questions also. One from Dr. Muhammad Qabil. Any clear indications or contraindications for oral polyethylene-based plates?
Yes, of course. The old poly tibia were the original tibial components that was present in the market 20 or 25 years ago. They have diminished and disappeared because of the high wear concern. They reappeared again in US and in many Western countries because of two concepts. First, concept related to the cost. They are much cheaper than the ordinary metal bagged tibial components. Faster surgical technique, and they are mainly indicated for patients with a relatively low life expectancy. These designs, all tibia polyethylene, are mainly introduced for patients in the sanitary houses, patients in shelters, very elderly or end-stage tumor patients with advanced osteoarthritis stage of the disease. That's to say, you are putting this all poly tibia in patients with life expectancy within 5, 6, 7 years, something like this. You need a cheap component that puts a lower burden on the insurance system of the country, faster for the patient, faster for the surgeon, forgiving, and not expected to serve high demand or high stress. That's the indication of all tibia. That's why it's coming again these days.
Another question, Dr. Wael. Time frame to move from partial with bearing to full with bearing with different procedures.
This is not related to the implant design. The time for shifting from partial root bearing to full root bearing depends on the surgical technique, how much you are confident of your surgery and your balanced gaps, and the cooperation of the patient and the rehabilitation with physiotherapy. So this is not something related to the implant design. It's related mainly to the surgical technique and rehabilitation.
Another question, do you recommend using CPM after primary post-stabilizing or shape retaining design?
I'm routinely using CPM. I'm routinely using what's known as the AV pump or arteriovenous pump as a mechanical method to avoid DVT. And I think in the first 3 or 4 days post-operative, if the patient is in the hospital, it makes major shifts and major progress in the knee range and the rehabilitation of the patient.
Thank you, Dr. Wael Nassar, for your valuable presentation and your valuable lecture. And thank you, Dr. Muhammad Dashab, for his nice talk. And
thank you, Dr. Hussam, and thank you so much, Professor Dr. Wael Nassar. This is a very demanding talk, patient selection and implant selection. I think no one can speak about it such like you, sir. It's a marvelous talk and demanding talk. Thank you so much for your precious time. It was a pleasure, sir. Thank you so much. I hope to see you in many other talks in our course, sir. Thank you so much. I'm very happy with the last picture. Remember me with the beautiful old days. I hope it will come again, sir.
Inshallah.
Thank you. Thank you so much, Dr. Wael. Thank you so much. Thank you. We are very, very honored with the presence of our eminent professor, Dr. Wael Nassar. The next talk, inshallah, will be on next Saturday, 20th of June. It's talking about total knee replacement in deformed knees, varus, valgus, and flexion knee. The speaker will be Professor Dr. Ayman Abid, Monofia University, one of the superstars of arthroplasty, knee and hip arthroplasty in Egypt. I hope to see you next Saturday, inshallah. Thank you so much. Have a nice night. Thank you.